Yeah, the numbers are going up now, so people started joining.
Yes, we are on, Ken.
Thank you. Hi, everyone. We'll just give it a minute or two to get started because people are starting to join. Want to give people another minute. People are still joining, so we'll just give it a few more seconds before we get going. Hello, everyone. I'm Ken Mayer from the Harvard CFAR, and I'm pleased to invite you here today to this antiretroviral prevention webinar, along with my co-facilitator of this science group, Patrick Sullivan of the Emory CFAR. We're very fortunate today to have with us a very distinguished visitor, our colleague, Dr. Rupa Patel, who's the Chief Biomedical Prevention Activity Lead at the CDC and really the point person for all things PrEP. Rupa did her postgraduate training and was a faculty member at Washington University in St. Louis before moving to Washington, D.C., where she has directed biomedical prevention activities at Whitman Walker Health Center and has subsequently now taken this position at the CDC. Rupa is a very creative thinker and thought leader, and we're very fortunate to have her both at the CDC and to have her with us today. And she's going to follow up on the excellent talk that she gave at CROI and give us a further update on the current status of injectable cabotegravir for PrEP implementation. Just as a reminder, we meet every other month, the first Monday of the month. So we'll meet again in October. Patrick Sullivan will be monitoring the chat. So please put your questions in the chat. And after Rupa's finishes her remarks, we'll have some time for Q&A. So thank you for being here, Rupa. Really appreciate it.
Thank you, Ken. It's an honor to address this group. And I first wanted to meet everyone. I know this is an NIH geared talk. I sit in the CDC. As Ken said, I'm a clinical biomedical prevention activity lead. I've taken the late Dawn Smith's role, if you've heard of her. And in that, I also am the lead subject matter expert for the PrEP guidelines, and we'll put that together. And so that's very important because I'm coming to the NIH and the audience today and the CFAR network really directed towards young and mid investigators as well as mentors on how the science we produce can really impact national guidance and some of the loopholes that or gaps we may not be aware of if we don't see the entire spectrum of from science to actual delivery. So in this talk, I'll present a framework. I want to kind of remind people of the organogram of the CDC. This is very important for the impact of your work. I lie in the center for HIV, hepatitis, and STD and TB prevention. And then we're in the branch of, or the division of HIV prevention. And there lies an HIV research branch, both for research teams as well as prevention research. We collaborate with investigators, many of you in the room. So it's important to know that you can reach out to the CDC and connect with us, anything from modeling to thinking about even diagnostic testing, as well as even implementation studies. And so today we'll go over the purpose of the talk is implementation challenges, mainly for injectables. I'll pull quite a bit of content from the presentation that was in May or March 2024 and build on that where the researchers can actually dive in. I will apply what we talk about for cabotegravir in the context of injectables. And I want everyone to take that away. Cabotegravir is just the springboard for the era of injectables and the era of long acting. And a lot of this is really the call to action in the place that I sit is how do we impact national guidelines in real time in order to impact delivery directly, so to curb HIV incidents. Before I get started into some of the meat of the challenges and call to action, there's 3 important contextual points regarding PrEP that I have to bring up to researchers, because while we face those challenges, and that was very evident for acquisition of meds and cost, and that being a driver for low PrEP uptake, I want to, for those of you in the room that don't live and breathe health department and PrEP policy, really what CDC funds, it's important to know this context. And again, the pipeline. First, I have to acknowledge at AIDS 2024, we had groundbreaking evidence for lenacapavir. I'm not going to dive into the science because this audience can digest the New England Journal of Medicine article, but I'm going to weave in what science we need immediately when this product is FDA approved in order to reap its benefits, which is some of the literature that is not necessarily domestically available. And that's very important. This is a domestic geared talk. And so the challenges and the gaps in research and clinical delivery will be geared towards that. The next is we have a lot of science. The science just not as domestically produced or doesn't have domestic applications. And that's been one critical pitfall in how guidance can be made when we're actually grading guidance. And so I want to highlight there's global delivery and examples that we can all learn from, and there's contextual differences. And I think the stark one, when we start looking at oral PrEP and pharmacies in Kenya, everything to Cabrolette, I'm not going to dive into the data. This was all described in CROI, and you can look that up, and IAS AIDS 2024. But you know, the key here is really what are the policies in Africa or Asia that are allowing mobile clinics, youth clubs, schools, the integration of you know, clinics and community health workers, mail-in. These are demonstration projects from China to Kenya. And lastly, to the right of the screen, you know, you have what we've called Dean Express in London. You've got the quick depots that are launched in Africa. And so what's really striking is when product is available in some of these contexts, for example, at the Desmond Tutu Health Foundation, you know, within a week, they're able to roll out 80 injections. As you'll see later in the slides, since it's a domestic focus and this is just context, you'll see we haven't had more than around 300 to 400 injections around the nation at one center. So this is really striking about product availability and then the settings that we're in. I also want to highlight there's a different context that's keeping us behind. When you look at FDA approval of diagnostics, that's going to be our rate limiting step. Hot off the press, please, researchers, this is very important. Please look at the WHO new implementation tool. Please look at their differentiated service delivery guidelines. And please look at these HIV testing services guidelines. And the reason I'm bringing up to our domestic researchers, and a lot of you in this CFAR talk I know are also global researchers, so the call to action if you're doing global research is can you try to partner with your domestic CFAR network so that we're getting the science locally to impact guidance. What was striking to know is that for the first time, you know, we can use self-testing to monitor PrEP in the global setting. And the reason I'm bringing this up is because those diagnostics, they have 6 FDA approved diagnostics or WHO approved diagnostics where you have, you know, decent antigen antibody and also they've endorsed antibody only testing. We can talk about the discrepancies of is, you know, who wants what in what location. But when you have differences in diagnostics it allows us to build on the great work that we've seen about teleprep or other things in the United States, where we can start moving things out of the clinic. And that's one of the issues that I'll talk about later today when I discuss some of the more items that researchers can actually actually do the research on the gaps. The third context is we talk about cost. It is an issue. I don't want to, really focus on this too much in today's talk, because we understand in the United States, most of our products are at an elevated cost. We have a patchy system for healthcare. Those of you that are doing the randomized control trials on delivery methods or certain, bio kind of technology related to PrEP, I do want to put that in the context of what you may not be looking at the literature or studying yourself, and that's all the cost and modeling. And the reason I bring it up is because cost is the most proximal issue, and so is insurance coverage. If you can't get the product for somebody in the United States due to cost and prior authorizations, the issue around that, different than the African countries about availability of a product and that product being funded through PEPFAR or the Ministry of Health, you can't get a mobile van to work. You can't do PrEP at home. You can't do many things downstream. And so I think we have to acknowledge that and do the best we can about task shifting and sharing with the labor market and human beings and the workforce to deliver PrEP, the settings in which we can deliver it, and some of the packages we can offer PrEP and going in lines with the WHO differentiated service delivery. Just a few bullet points. So we've discussed cost as the most proximal factor. This is information from the CDC that I wanted to update. One is we've looked at recently in CROI, in a paper being published soon in Clearance, is about the out-of-pocket costs for ancillary services. A lot of us know about meds. For the first time, you had ancillary services that includes an office visit and labs, actually costing at least $226 out of pocket. Remember, that has nothing to do about your deductible with the medications. And what's really disheartening is 50% of the service costs are for providers. Why I want to bring that up to you is because reimbursement is real. And as you do your studies, it is really important to have randomized control trials that are helping to grade evidence on, pharmacists, community health workers, nurse practitioners, MAs are non-inferior to the current status quo of doctors and physician assistants and maybe nurse practitioners that help us with reimbursement and also help us kind of tease out the service costs. The next thing I want to talk about after we discuss the bulk of out-of-pocket costs for ancillary services was just a quick and dirty database, study on looking at MarketScan. All of these presentations I'm giving you regarding the cost of meds and out-of-pocket costs for ancillary services are essentially done through the CDC, through the multiple data sets that are being used to triangulate the data, which includes MarketScan and some of the other medical claims database, Health Verity, etc. And so what I just want to highlight is that the cash of if you didn't have insurance, that medication cost was around $800. So this is just giving you a benchmark of, the amount of money people are paying per out of income. And then I just want to highlight some of the cost issues. The late Don Smith presented work with Dr. Bonassi in Health Affairs to show cumulatively $100 million were accounted for in 2018 regarding the total out-of-pocket costs we could expect that every PrEP user cumulatively was accounting for. And, this equates to PrEP abandonment, including, which helps us do our research along the PrEP care continuum and initiation and retention. And that abandonment has 48% kind of abandonment rates with out-of-pocket costs at $500. Again, nothing new, just highlighting in the context of what we know in oral PrEP. This is important, because if we know about it in oral PrEP, it's going to translate to CAB. And so this will be why we have low rates of CAB. I want to go into Medicaid, and this is important for my next slides about how state level patch up systems are happening. We know that when you have some form of universal health care, which can be looked at the state level as having Medicaid, a safety net for people that don't have commercial insurance, you essentially have higher rates of PrEP use compared to the number of diagnoses in that locale. And so the top graph in the left has a purple line where you have, when you have Medicaid expansion and increased eligibility to have coverage, you essentially have PrEP use increase over time, and you have a flat line when you don't have expansion. Again, very common sense, but wanted to show you the data around it. This may be new to many people. We must acknowledge that there are state level cost solutions. And this is part of the call to action that I wanted to bring up to researchers, is when you're doing your randomized control trials and you're creating implementation science packages, please incorporate and try to evaluate some of the existing mechanisms so that we can scale them up. And I know that seems like a very basic a statement, but it's true, because it's hard to grade evidence and it's hard to process what a state's doing and scale up if we're making brand new things and not acknowledging the current things laid out by each health department or each CDC or HRSA product. And I'll go into what I mean by HRSA and CDC products when we talk about a few more slides. This is really important. Each state, and as researchers, you really need to get to understand that, because it's going to impact the downstream mechanisms of cabotegravir and lenacapavir. Each state creates a medication drug assistance program, and we knew that from a long time, from the first time we had PrEP called Truvada. But what has expanded since then is you have full insurances. These are called public health insurance programs, where you have states that are now covering labs, the office visit, and primary care services. This is a snapshot from Colorado. I ask all of you researchers in the room to figure out what your state is doing, and as you develop your cohorts and your multiple sites, to really dive in and see how you can leverage what the state's doing. So what I wanted to highlight is in the middle of the slide, what is fascinating is the patchwork of funding that comes out of it. You've got tobacco settlements here, you've got in Ohio, you have treasury funds, and who distributes it is your local health network, which could actually be your federally qualified health centers or community health centers, which are your safety net backbone of the United States. And then you have other entities, and then you'll actually have, what's very interesting is a pharmacy may be attached to that, which will be very important as you do your claims data. So, I hope as you look at your metrics and your outcomes and you're using initiation or intention, you're using the metrics of pharmacy claims, please don't discount some of these robust mechanisms where you have implementation and you can connect with these pharmacies. And they have an insurance card. Again, this may be very basic, but it's a deep level of context that you must have in order to have really downstream impact. What's important on this slide is they've broken up your insurance types, which is an impediment to any type of PrEP delivery in the United States. And I want to highlight, you have the insured, you have the uninsured. And when you have the insured, you have the underinsured. and you have the fully insured, and it is these underinsured individuals that have high deductibles. Again, if you've been in this field for a very long time, I'm preaching to the choir. If you are a junior faculty member, this may be quite new to you and is important to understand, because it'll be really the issue that we have for the next decade when trying to get PrEP rollout to where we need it. And you'll have these slides. I really want you to take a look at the underinsured situation and how that's being patched up by these tobacco settlement funds in this case of Colorado. Next, I wanted to do a deep dive into the framework where I saw the NIH researchers really connecting with the policymakers at HRSA and CDC, and then moving downstream from there. Take a step back. There's a lot going on. I'm going to take you from the left to the right. So first is the science. This is you. This is the randomized control trials you make. These are the step wedge trials that you do with hybrid science from implementation science. What you need to understand is when you create that science, that will impact to the right our national guidance. It'll impact FDA approval. That's a loop. Health regulatory approvals and FDA approval impact national guidance. And as you create the science, your communication is really important. I've put in that iconic Twitter page from Julia Marcus because we all refer to it. We all kind of, even in guidance for certain locations, including possible future CDC guidance, as well as some country level guidance. We've referred to these, what has come out from researchers that have been highly visual and highly effective, which has given the communication that we've needed for advocates and scientists to work together. And when I say communicating the science is so that we're promoting multidisciplinary advocacy. Some great hallmarks are also from AVAC. I can't understress the amount of graphics and language AVAC has done, and that carries over all the way to the right of the slide as you go through all these elements. What's really important now, as someone who's actually grading the evidence in the thick of things, when we look at CDC guidance, we look at the raw clinical guidance. That is, what tests you need for initiation, for monitoring, what in those tests, what types of tests do you need? Do you need RNA testing? Do you need antigen antibody testing? We've seen that work come out of HPTN in AIDS 2024. What I wanted to then take you is that for us to push the guidance for the CDC and other normative agencies to move around implementation, which again, not going into that deep science, the deep dive in statistics, but all of us know who have been in this for the last 5 years have known that the numbers have been low in order to reach the certain populations that would benefit from PrEP. And that has been distally, that's from the implementation gaps that we have, largely related to cost and insurance coverage and medication acquisition. But also we're and I'm going to come back to this, we're missing the strength of the evidence in order to grade for grade 1 and 2 and A and B in terms of task shifting and task sharing. We hear about pharmacy-based PrEP all the time. Where are the non-inferiority studies where you have pharmacists that are non-inferior to status quo? Unfortunately, in the real world, we know there's no issue, but when we grade evidence and create a recommendation, we need that. I want to also highlight the setting also of pharmacies has not been in that graded evidence. I also want to highlight when you're starting to look at teleprep and the evidence behind that, the number of clinical trials to give you that strength. We've also got, in terms of when you look at differentiated service delivery of care, we haven't incorporated community health workers or other task shifting. We know CAB is being implemented by RNs and MAs, and I'll present that. So that takes me back to to the left, when you have FDA approval, that's important, but also the other regulatory approval that we haven't seen that the researchers in the room have to start diving into and working with other distal policy researchers is, can we have states and can we have cities also go ahead and give us an opening into regulation? Will we have that, just like we had telehealth was okay and we could have multiple medical license in multiple states? The question too is community health workers included in licensed injection administrators? Is medical assistants included in injection licensed providers? Who is your licensed provider team as we go into implementing lenacapavir in the future, the current versions of cabotegravir, and the next forms of long-acting injectables? I didn't present it in this slide set, but you can refer back to CROI and you can refer back to some other data and presentations. But in Washington State, the governor has passed iconic law where disease intervention specialists or DHS officers can now be an approved form of providers for injectables and can have a certain certification. That's going to be really important to have a syndemic approach to syphilis, possibly mental health, to HIV prevention and STI and prevention when you talk about gonorrhea and ceftriaxone. That's really important. So what I wanted to get at is not only are you talking about who and where do we need graded evidence, we're talking the policies around that. And the next set that's really important is the diagnostics. We have a lot of kits being used today. I want to remind the researchers, which was new to me, it is very hard to put any of those kits into normative guidance because it is not FDA approved. And we don't have FDA approval. To get FDA approval for these types of diagnostics requires certain data and certain funding. So the call to action is, can we get more diagnostics down the road so that we can incorporate it in CDC guidance, which will then go to the right, which is the delivery of care. I'll come back to more aspects of CDC guidance. It is very, very important that when you have normative guidance, that impacts CMS, that impacts the US task force, and how insurance coverage is created. And so I gave you the cost data, but it's important to have graded evidence that pharmacists and pharmacies are non-inferior to delivering care so that they can ultimately, hopefully down the spectrum, be reimbursed. And that is important for this type of reimbursement. Next, our education is being produced. I put this slide very importantly because we have so many toolkits created. We have a lot of provider-driven interventions. We have a lot of client package interventions. We have technology. This is the call to action in order to scale up and to be able to continue incorporating the menu of options we have. Again, I'm CDC focused at this point. We have the best practice compendium on the website. We have a teleprep hub, and we have technical centers. Where I'm going with this is that if you can have your work directly communicate with those end deliverables for national guidance and then education and skills building, that will really be directly impactful. And as you're upgrading what is currently available, can you actually incorporate, use what is out there as a springboard so as not to reinvent the wheel? And the communication is important. I'm spending a lot of time, because this is the hallmark of my talk and why it was so important for me to reach out to you all, is we recommend that the researchers in this room actually come to the CDC and communicate, come and reach out to, come to a trip and disseminate your science on the Division of HIV Prevention portal that helps us integrate your work and collaborate. It helps us to inform our NOFOs. It directly feeds into our capacity building network. It impacts our prep curricula. It impacts the prep line. This is also the menu for those of you that really have your heads focused in developing the science. This is how your science is incorporated in that technical assistance, capacity building network. It is in the curriculum, it is in the hotline, it is in HRSA funded entities such as Fenway's National LGBTQI Health Education Center. It's all CDC funded. And this is really important. This affects the guidance and the education that we deliver to CDC funded CBOs and our health departments and our safety net centers, which is the bedrock of delivery of care. Where I'm going with all of these spectrums or elements, where you have healthcare coverage, you have education, this all culminates in the context of what you have FDA and CDC to delivery of care by organization type, which I'll go into detail when we talk about CBOs, academic centers, private clinics, and you have public health departments, and you have safety net centers. And within those, you have HIV specialties, you have women's health, you have primary care, which is the fundamental way of getting individuals their vaccines and everything. Most of you researchers in this room have contributed to the science that PrEP is the gateway to care. And it is important as that people come in, clients have an unmet need for vaccines, for mental health, for substance use. I'm going to move on to the next slide where I'm going to set the stage. So in general, I wanted to give you the context of where CAB lies today with the pipeline and the cost, and when you have oral PrEP having these cost impacts CAB. Next, I gave you the framework in which I wanted to have you look at the lens of all of this for the call to action to have you more robustly assist with national guidance and the strength of the grading of the evidence. To lay out where we are right now, the data from 2022 shows that over time that we have 50% of generics and we have low CAB use. I'm just giving you where we are in the state of CAB, 0.5%. And remember, when you have a first dose, you start looking at the second dose, which is 1 month later, you have great uptake. The issue is where the disparities of current CAB use are. You still have a low, just in the context of oral PrEP, you have low kind of prescribing and delivery to females. And in general, you're hitting 13 to 34-year-olds. This is an adaptation of the CROI presentation. I wanted to highlight certain things that I could not do during CROI because it's going to be really important for the researchers today. You know, there are different organizational types that will need to be documented as the landscape for delivering injectables. And why I say that is because, as I'll discuss in the next slide, the injection is a whole new paradigm. The deep understanding of the injection is that it comes into a person, into a clinic's, actual pharmacy or clinic, and it's in the hands of the providers. That has caused a new element of medicalization, remedicalization. I want to do a time check because I can't see any type of the screen. Alberto, can I have how much time I have left?
I think you could 10 more minutes. Yeah, it's
Okay, thank you.
12:35, but you can go longer if you
Thank
need to.
And so my apologies for the interruption. The issue that I wanted to highlight is the black star. And as I orient you to the stars on the right-hand corner is the black. And so the stars are actually the organization type. Red is Federal Health Center. We have health departments in the orange. We have community health workers, and we have an academic private centers. And what was important is the green star, the other in the stars, the tried and stopped in the outsourced work. When you have an injection that comes to a very high volume healthcare center that is already stretched, such as a primary safety net center, where the call to action is where we need to implement and scale up in those networks. There is a problem with staffing and scheduling and the dashboards related to that and how to optimize these inefficiencies. We're going to see more people outsource. We saw outsourcing starting to occur by large private center in Orlando. And what I mean by outsourcing is that a prescription will be made by a provider, and then they might have a whole nother entity, including people who fill follow-up prescriptions, as well as injecting and medical record documentation. And there will be a whole loop and feedback cycle and monitoring related to that. I can see that transitioning over to pharmacists as well, if your state allows pharmacy injections. That is a certain typology that's going to come about, as well as the typology in the green you'll see in the middle, where there's an academic private center, which is yellow. And there, I'm going to put my cursor, and I don't know if the cursor will show. There's yellow and there's green. That is actually what we're not capturing when we're going to conferences like CROI and AIDS. We are not capturing the amount of people that have not been able to start, or have started with 3 people and they couldn't keep up, and so they actually stopped. We've actually been able to capture the yellows, and the yellows are really important. They're peppered through essentially the academic centers in Florida, in Alabama, Louisiana, and also the West Coast. And the outline of these stars have been the numbers. And when you start looking at less than 100, that's really problematic after 2 to 3 years of FDA approval. But on top of that, all the lessons learned from a decade of oral prep, with also acknowledging all the cost stuffs we've already had. A lot of these centers are HPTN sites and have not been able to get past their 30, that they're just trying to ethically transition to the real world, or they've decided to stop and they've said, I just want to get our 30. And then I'm going to try to transition them to a larger healthcare center if the state of Texas has one. And then I want to talk about the 3 federally qualified health centers that have actually been able to have the highest rates of prep in terms of the numbers and the rate of growth. And that's Legacy, Howard Brown, and Whitman Walker. But I just want to highlight, nobody is past around 380 at this point at one single site. And there will be implementation gaps as we have churning. So when you look at these slides in detail in the future, you'll have to acknowledge in all demonstration projects and implementation science studies, can you look at interventions where you had your intervention plus non-inferiority or superiority in certain organization types to the right, federally health center, in that legend, and then also geographic wise, and then also the rate of growth. And that is really going to help us at the implementation level of national guidance when we're talking about graded guidance. To the right of the slide, what's really important is the mobile vans. You'll see a lack of uptake of moving out of the clinic because of medicine acquisition. And so we need to acknowledge that. But as you continue to do your research, the push is, can you get us out of clinics sooner than later and in time when lenacapavir is FDA approved? Briefly, the workflow challenges are where I want to highlight where the researchers come in is to the right of the slide. I gave you the evidence of oral prep and cabotegravir prep having a really hard time with the existing system of the United States healthcare when we talk about insurance prior authorization. I'm not going to go into detail with buy and bill and pharmacy benefit. It's very distal in implementation, but please acknowledge that there's researchers in this group that's really That's their sole focus. I've talked about remedicalization when the injections have to come to the doctor's office, but where the current implementation science researchers come in is to the right. The most accurate diagnosis of missed appointments, where we know 1 out of 5 is in missed appointments when you cumulatively look at CROI data, the emerging abstracts coming out cumulatively with single center. Can we make more multi-centered research projects where we're defining the cabotegravir and injection continuum of care, where we're looking at missed appointments and creating the dashboards that are really important to help us then continue going into the orange, which is documenting discontinuation, restart, switch, and the concept of biomedical coverage. And we don't have an accurate understanding of the cumulative DC rate by organization type and geography. We know it's up to 15% through the accumulation of data. In terms of stops and starts, we have a general idea that insurance and cost is an impact. But in terms of other destroy choice experiments, we know they're coming out. The data is telling between MSM and cisgender women, there's an overwhelming desire for injectables, even looking at the open label HPTN. But now that places like Whitman Walker, Legacy Health, and Howard Brown are about a year out, we now just need to start seeing, are people continuing? Also, we need to, we have a gap in trans care and injectables that will remain an issue, partly because we don't have alternative sites and we have implants and the where the injection is being an issue. On-time injections is really important. We've noticed through the data, plus or minus 14 days, we have high retention and on-time injections, but that will fall into discontinuations. Really the call to action here, before I transition to my last 3 slides, is we really need more real-time data at local centers for demonstration projects. And that's been a gap when we're looking at non-clinical trials and trying to look at national guidance and getting us into an implementation set of guidance. Where are the demo projects from multiple safety net centers that are showing us what works and what doesn't, so we can actually guide medical directors and recommend with graded evidence that this is what's been proven, and hopefully that will go downstream into that will be covered as well when you're talking about reimbursement, and we're talking about when we write letters to insurance companies. The strength of the evidence on the right-hand side of this slide is really important, especially the gray on the bottom, the medical documentation and billing, and the M&E system. An example is Whitman Walker does have a real-time dashboard that the EHR dumps into eClinicalWorks, which is their EHR, dumps into a real-time dashboard where their quality improvement staff actually can go in real time and create graphs and go to a provider and say your clients have missed their appointments. I would like to see if we can create more of these so that we're getting a better understanding of what's happening in the real world. I think the collaboration with academicians such as yourself, with the local safety net centers and shared resource for funding to create these dashboards is now the call to action, because the injectables have to move out of the clinic and have to be in mobile vans and in homes. And we'll need more real-time data to see who's missing their injection when you had a van in Ward 8 in Washington, D.C. This slide is the CFIR framework where you can study it really in depth. The reason I'm not going into it is because we talked about the 5 domains in great detail: the intervention, outer setting, the individuals, the organization level, and the process. Where we're going to need more research from you all is the organizational level setting, as I was saying, with the graded evidence of what's working to have medical directors to commit to injectables, and then the workflow really moving us forward into understanding the care continuum and what further interventions we need to drive that. I'm going back to this slide because this was the hallmark. We can answer questions regarding to where you fit in the Q&A. And we discussed a lot, but please hone in the middle. Think about every NIH grant you write, every R2134, R01. How does this fit into the graded evidence? And who are your other colleagues that are giving us the cumulative evidence in order to create that graded statement and get voted on the guideline committee? I wanted to conclude, we discussed CAB rollout and the multiple issues. The reason we have low CAB rollout is really regarding, in the current day, cost and acquisition issues. And that is going to be what's happening with lenacapavir, but we have to move beyond that for the implementation level interventions and the science that impacts our guidance. And then I had really importantly, as my kind of debut in front of the CFAR network and the NIH, I really wanted to take you into the guidelines creation and where you fall in the different facets that your work can impact delivery directly. I'm gonna stop there and go into the Q&A and hand it over to the moderator.
Hey, thank you so much for that talk. And I can promise you there's lots of, it will generate a lot of good discussion, and I think is already for myself and our colleagues who are on the line, taking notes about how we can use this to shape ideas and move forward with NIH and other applications. So just a great talk, and thank you. Thank you for the talk. We are going to start off with the first question we have in the chat. I want to encourage folks, if you have questions, you can put up your hands if you want to ask them verbally, or you can pop them in the chat and I'll moderate them. And so let's just jump in. I'm going to read a bit of this just because not everybody may be able to see it in the chat. I'm not sure if it came over, but so Haley Cunningham said, I work at a large academic medical center that offers cabotegravir in its ID clinic, but many patients have trouble getting to the clinic. How would payment structure work if a mobile clinic were implemented? Could this be an extension of the infectious disease clinic so the clinic is reimbursed for this care?
That's a wonderful question. The first answer to this is that many federally qualified health centers in the United States have a community health department. And I have to give background, when I moved from Washington University in St. Louis, I moved to Whitman Walker, and I moved there on purpose when I noticed they had a community health department attached to their federally qualified health center division. And usually how the framework works, and many, such as Fenway Health and many aspects have this, they'll have a medical department and they'll have a community department. And that is the extension of where you have HIV testing, possibly the integration of same-day prep, same-day ART. You'll have the integration of mobile vans. These mobile vans exist in Miami. They exist in Whitman Walker. Howard Brown may have elements of this. I don't want to speak for my colleagues, but I've noticed that there are ways that the Federally Qualified Health Center, with their 340B funding and other grants, are moving into the field. And what they're doing is they're bouncing off and using their medical department to give them that supervision and oversight. So you can have standing orders with the nurse that goes into the field, and those medical practitioners are sitting in the medical division. And for the deep understanding on the clinical side for the NIH researchers is that please don't underestimate the power of the collaborative agreement. Medical doctors can use their medical license to connect with several pharmacists, several nurse practitioners that already happens. And so you have task sharing, because that is the only way actually we can run injection clinics, where we're servicing an injection clinic, including cabotegravir, ceftriaxone, bicillin for syphilis treatment. So in that sense, there may be a funding structure. It may be through grants and 340B, or if the doctor's involved, there may be reimbursement through that for the office visit and the actual labs. And that's important. Remember, labs, office visit, and meds. The meds are usually covered in some way. An example of that is the Federally Qualified Health Center in Mississippi, which I forgot to highlight that we're not doing enough about. They're actually using their 340B to give everybody health insurance, so that then everybody has everything covered over time, and you don't have insurance churning. So they may cover someone's health insurance premium for 3 years. No one has studied that. Like that is amazing, and could be the key to retention over time, if we're seeing insurance churning in the South being an issue. I can take some follow-up questions regarding the concept of that.
Great. I'll put out another question from Dr. Valeria Contos, who asked, what are the implementation research priorities related to optimization of long-acting injectable PrEP care delivery in FQHCs particularly? What do you think some of the main research priorities are?
Yeah, I want to take you back to the flow slide, and that's really important. I'm going to share screen if you don't mind, moderators, because it's a dense slide, and you know, it's hard to really understand this when you're not living and breathing the clinical part. I do want to put a caveat. I am still a practitioner at Whitman Walker Health in the community division, and I'm also, what that means is I'm also the medical liaison advisor for that. And you really have to sit and hear the conversations weekly over time dynamically to understand what's going on. And so to really hone in on what you're saying is really think about the blue. And that is, how are schedules being made when your client misses an appointment? Because the hallmark of the Safety Net Center, which is amazing, is that it really takes everyone through the door and subsidizes their care. And those Safety Net Centers also have been learning how to have vouchers for Uber and Lyft and other transportation. They've really had mechanisms to bring people in. And so when they're doing that, what are the missed appointments? Why are there missed appointments? Are they able to get them in? We showed at Whitman Walker, and a couple of other centers showed this. You know, you can get them in 14 to 21 days. And so while you have retention issues, people are coming in when you have a robust set of peer navigators to call and schedulers. The next set after the blue is we don't know enough about biomedical coverage. When, you know, we don't understand this enough. When you stop an injection, whether it's planned or unplanned, many of us are prescribing one 30-day prescription, because if somebody unexpectedly cannot get to the clinic, which is the remedicalization and the call to action to move the injections out of the clinic, is that they won't lose the concept of biomedical coverage. That means once their PK starts going down of cabotegravir, can I get them back up on FTC and TDF so that they're getting some coverage? And we know time to protection is 2 pills that day for men who have sex with men, and gay bisexual men, and trans men, trans women. And so are you seeing gaps in people take their oral PrEP until you get them back in care. And that's going to happen also when people are discontinuing because they don't like the injection site reaction. Remember with lenacapavir, this is really, really important. It is a different mode of delivery in the abdomen. And it is only in time and in the real world we'll see what happens with those injections in the abdomen and how is that comparing to the deep intramuscular injection with the buttock with cabotegravir. So it's the teal in here, it's going to be the orange, and it's going to be also the gray, and that optimization of some type of dashboard and getting the data from safety nets collectively.
Great. And you said you can share these slides? Can you
Yes, 100%.
Yeah, because that'll help our colleagues who are thinking about grants. I'm going to ask you one more quick question. It's a speed round because we have a couple minutes left. And this is, I'll summarize our question from our colleague, Aaron Siegler, who sort of reflects on the importance of the remote specimen collection kits and having those FDA approved to be able to look at sort of remote prep provision. And just reminding us that it is a long process to get FDA to approve these. And so just thinking about whether there's any way CDC can help, communicate the importance of this from a public health perspective and streamline the process for having the self-monitoring kits available under FDA blessing, because they are currently being used, but they're in a regulatory interesting place. So any thoughts just about how to work with CDC's federal partners and within HHS to make this a priority?
Aaron, I want to highlight that is a really important issue that we're having with the scale up of the kits. As far as on behalf of CDC and commenting on how to get those FDA approved, I don't have any jurisdiction to do that.
Okay. Well, that brings us to the end of our session. I want to thank, if you can thank through your emojis or in other ways, thank Dr. Patel for this talk, which really just, I think, gives us a high level view and is really thought-provoking about the directions that we need to head in. So we're really grateful for the talk. And we will follow up with you about future webinars. These happen every couple months. And Ken, do you want to provide anything else in closing?
No, just thank you, Rupa, very much. I think Alberto said that our next call is October 1st, but that's actually a Tuesday. And I just realized that HIV R4P will be October 7th. So we may have to think creatively about scheduling, but we'll send an announcement to everybody on this e-list when we figure that out. But Rupa, thank you for fantastic.
If you're not on the e-list, you can email Ken or me or Alberto, and we'll get you on the list. So thanks again to Dr. Patel. I'm really grateful and hope everybody has a good afternoon.
Thank you. Thank you.
That was great, Rupa. We definitely want to look at your slides a lot there. Really appreciate it.
Thanks, Ken.
Take care. Thank you.
Bye.
Really.